try my best to do justice to this topic which I've been given to present. The topics on fetal growth restriction is diagnosis and management. The outline of my presentation, first I'm going to talk about definition. Okay, first I'm going to talk about definition. And then also I'm going to touch on the rights I'll touch on the engagements, and then I will conclude. So by definition, fetal growth is when a fetus is failing to achieve its genetically predetermined growth potential. Now, this is quite difficult. We have a pregnant woman with a baby inside, and we don't know what its growth potential is. But then we're saying that for us to diagnose fetal growth restriction, then it's failing to achieve its genetically predetermined growth potential. So I think you understand this is actually a functional definition, and it seeks to identify fetuses at risk of modifiable but otherwise poor outcome. And then here comes the definition, which Mr. Zanga has done justice to, small for gestational age. And I think as clinicians, we are quite comfortable with this gestation because it's very easy for us to diagnose babies with suffering from who are small for gestational age. That is, these babies are falling below a predefined threshold. And most of the time we use 10% as our predefined threshold. So if a baby has an estimated fetal weight or abdominal circumference which is less than the 10th center of a given reference range, then it's very clear this baby is small for gestational age. But then what is very important is this: small for gestational age is not synonymous with fetal growth restriction. If I was Mr. Sanga this time, I'd say, please say to your neighbor, small for gestational age is not synonymous with fetal growth restriction. This is very, very important. What we have realized is this: within the small for gestational age, there are actually 3 subgroups. There are those who are constitutionally small fetuses. Basically, this baby is small, but it's a healthy small baby. And then there are those who are pathologically small fetuses. Mr. Zanga already mentioned that these babies might have aneuploidies, they might have some congenital infection, whereby they're failing to grow well. And then we have this group of starving small fetuses. Now, we're not talking about fetal growth restriction. We are referring to these small starving fetuses who, because of usually mainly placental insufficiency, they are failing to achieve their predefined growth potential. And then many fetuses with fetal growth restriction are actually found within this small for gestational age category. So what is important for us to note is that, yes, we must flag all babies with small for gestational age, because when we do this diagnosis that they are small for gestational age is actually pivotal. The identification of fetuses who are at risk of fetal growth restriction. I hope that's clear. I'll also give you this diagram, which Mr. Zanga showed you. In a study done by McCowan and others in 2005, what he noticed was that 10% of the fetuses were falling under this line here, and meaning that they were small for gestational age. But then within those 10%, 20% were actually normal small. These are babies were normal small. Then they were abnormal small, those pathologically small and those with fetal growth restriction were actually 65% starving small babies. But I also want to take you to this graph here on my right side. This graph is actually important because it actually shows that with fetuses with fetal growth restriction can actually also be appropriate, can be in the appropriate gestational age group. What do I mean by this? First of all, let's see these last two lines here. This baby here with these lines here, dotted lines, is small for gestational age. But if we continue plotting its weight on a graph, what we find that this baby is following its growth trajectory all throughout the pregnancy. So this is a healthy small baby. But this baby is small for gestational age. But it's small. And then this other baby is also small here, if you can see, with this continuous line. But as the baby continues to grow, I think you can see that it's falling off its growth trajectory. That's very important. That's how we pick up babies with fetal growth restriction within the small for gestational age group. As you continue monitoring them, then you find that they are actually going to drop off their growth trajectory. So this baby has fetal growth restriction. Then now within this gray zone, these are babies who we would say are actually appropriate for gestational age. But can you notice this baby, if we have been following up its trajectory, as they continue to grow, they actually fall off their growth trajectory. This is very important because these babies are the ones who we are missing in our clinics. We have only one scan and they say that the baby is 2.5 kgs and it's on the 25th centile. So you say everything is fine. But then if we're to measure its weight serially as the weeks go by, we find that actually it begins to fall down its growth trajectory. So this baby also is fetal growth restriction. I hope that's clear because we miss these ones a lot in our clinics. What I'm trying to say by this definition that fetal growth restriction is a common but complex problem. It affects on average about 10% of all pregnancies, and it will vary depending on your ethnic group and where you are. Fetuses are at increased risk of perinatal morbidity and mortality. And if they manage to survive the perinatal period, they're also at risk of in childhood of growth delay and also of neurodevelopmental impairment. But the problem does not only end there. In adults also, there's high risk of non-communicable disease, which are characterized by high blood pressure, dyslipidemia, obesity, and insulin resistance. So you see where your type 2 diabetes are coming from. Your strokes, only because the intrauterine environment was not friendly for these babies. So what is then our challenge as clinicians? Our challenge is to identify these fetuses with fetal growth restriction, whose health is endangered, not only in utero, but well into adulthood because of a hostile intrauterine environment. But by the same token, I know us clinicians, as soon as we see that the baby is small for gestational age, want to do something, want to deliver. But let me hasten to say, but by the same token, we should recognize small but healthy fetuses and avoid iatrogenic harm to these fetuses. So how do we identify pregnancies which are at risk of fetal growth restriction? Traditionally, what we do every day in clinic when we meet our patients for the very first time, we ask them a detailed history and we examine them. So we identify women with pre-existing risk factors of having a fetus with fetal growth restriction. We take their demographic data. Are they young, 20 years and below? Are they old, more than 40 years? And then when were they last pregnant, more than 10 years or so ago? Do they have any chronic illnesses? Are they chronic hypertensives? Are they diabetics? Predating the pregnancy? Do they have antiphospholipid syndrome? All this is helping us to risk stratify these women, find out if their babies are likely to have a fetal growth restriction. Then also, once the baby patient is on the couch, we also examine the symphyseal fundal height. The aim is trying to find out if it's corresponding to the date that the patient has, or if it's smaller, then we say there's something wrong because this pregnancy appears to be a little bit smaller than the date. And so we can do further investigations. But more recently, there are also other ways that we can stratify these pregnancies. We can do Doppler velocimetry and also placental biomarkers. Currently, in our country, we can do Doppler velocimetry quite easily. Once you pass through the fetal medicine unit should be able to do this easily. So with the Dopplers, what we interrogate the uterine artery Doppler. So some of the things you can see there. Can I remove this? So we interrogate the uterine artery Doppler. This is the maternal uterine artery. What it does when you do this, it shows that the uteroplacental function. Normally in pregnancy, we all know this. There should be a physiologic transformation of the uterine arteries from high resistant channels to low resistant blood vessels. If this fails to happen, though, what happens is that there's going to be a persistence of high uterine artery resistance. And this will reflect when you scan the woman, when you do the Dopplers, as high pulsatility index, which with above the 95th centile is associated with placental insufficiency and fetal growth restriction. Investigations for this can be done as early as in the first trimester. So when your women are coming for that very first scan, between 11 to 13 weeks plus 6 days, you can actually do lots of things there. You are going to screen them from unemployed. You're also going to screen them for a number of other problems, but also in addition, you can also screen them find out if that baby is going to be to have fetal growth restriction. Only by doing this scan, just adding on the uterine artery Doppler from there. And then also at 19 to 23 weeks, we can also again do the same scan when they come from the anomaly scan. Again, this will say something about fetal growth restriction. But in this case, what we're looking at is late onset fetal growth restriction. Whereas the early one, if it's abnormal, then it says something about early onset fetal growth restriction. So as you can see from ESOP, the uterine artery Doppler velocimetry should be used to screen in the first trimester for preeclampsia and or fetal growth restriction. And also another thing that is very important here, if we do the screening very early in first trimester, it also gives us room to start using our aspirin, because you know that we can only use the aspirin up to 6 weeks of gestation. But then with these earlier methods of screening for fetal growth restriction, then it also gives us room that we can start using it even for women who not normally suspect that they may end up having a baby with fetal growth restriction. Once we've risk profiled them properly, that is. Then now as for biomarkers of fetal growth restriction, in this country, we can do PAP-A because it's actually being done as part of the combined test. But it's not really that widespread, the use of it. But then these two, there are lots of biomarkers actually which are causing a lot of interest. But I'm just going to mention these two, PAP-A and also a placental growth factor, because these ones are currently being used by the Fetal Medicine Foundation in the United Kingdom in risk stratifying women for preeclampsia and also for fetal growth restriction. That's why I'm going to mention them. But as I said, in this country, we are mainly using the scan and also the maternal history and then the physical examination. So as I said, this is an area of great interest. So PAP-A is a growth factor that acts on insulin-like growth factors binding proteins, which is produced by the syncytial trophoblast on the placenta. So when there are low concentration of PAP-A, one of the things that can happen in first trimester is that it shows that these babies are at increased risk to not only of fetal growth restriction, but of preterm delivery, preeclampsia, and stillbirth. One thing though that we need to note is that, as I said, actually being used for trimester screening from unemployed as well. So it can also be low in unemployed days. So once it is low, it is important that also we rule out that this baby does not have any chromosomal abnormalities. So when the baby does not have any chromosomal abnormalities, that's when we can use it as a marker for fetal growth restriction. I hope that's clear. Whereas the placental growth factor promotes development and maturation of the placental vascular system, and low levels of this will also precede the manifestation of preeclampsia and fetal growth restriction. And also it is high in first trimester. So if it's high in first trimester, then you can say that this patient, the baby is likely to be at risk of fetal growth restriction later on. So once we put up the women who are at high risk, we now have to make a diagnosis. But it's difficult for us to make a diagnosis. They are just a risk. But then we now need to know how do we actually make the diagnosis that this baby is now fetal growth restriction. So we put these women under surveillance. So that means that we're going to call them out for more scans. So when we do this, we are able to diagnose fetal growth restriction much earlier. And not only that, once we have this group of babies who are having fetal growth restriction, we can also assess the rate of clinical deterioration. We can also plan the appropriate interval to next review assessments. Because when we see the baby is deteriorating very fast, then we shorten also the intervals whereby we see them. But then if the baby appears stable, then we can also increase the interval, like you can see them after every 2 weeks. And then every time that we see the patient, then we have to also assess the risk that the baby can die in utero. That is for intrauterine DMS. Because that's what we're trying to run away from. That's why we're putting him under surveillance. That's why we're trying to get the diagnosis for fetal growth restriction. And then it also helps us to know when to administer antenatal steroids and to give magnesium sulfate. With the early onset fetal growth restriction, we always must give the antenatal steroids and magnesium sulfate timeously before delivery. And finally, as we continue seeing these patients, we can also make a decision, an informed decision of when should we do the delivery, the timing of the delivery. And then what is the place, where should we deliver the place that the baby, there's no point in having the patient deliver at the periphery, where the baby cannot be looked after. And then again, we can decide on mode of delivery. Some that can sometimes be very difficult for clinicians as they make a decision. Okay, this baby is term. Should I actually just induce the patient, or what else? Okay, how else should I deliver the baby? So when we are monitoring the baby like this, then also we have answers also for those difficult questions. This already has been Mr. Zanga has already said something about surveillance. In this case, what we're going to do, we're going to follow the fetal growth velocity. That's our surveillance. So it basically means that you're doing an ultrasound scan, whereby you measure the estimated fetal weight, overall, or the abdominal circumference. So what are you trying to see when you're calling the patient many times for this? What you want to see is there any reduced growth velocity? If the patient begins to fall, that's the baby. If the weight begins to fall, and then you notice that it has fallen by more than 50% or across 2 quarters, then that baby qualifies to be called fetal growth restricted, even if the overall weight is in the appropriate for gestational age. I hope that's clear. It's easier for us to pick in small for gestational age babies because we've already flagged them, but with appropriate for gestational age babies, usually for most of us, not easy because we miss that they're actually falling off their growth, that their growth velocity is actually decreasing. So this is very important. But what is of note that when you are using the abdominal circumference or estimated fetal weight, if at any one given time the baby's weight is less than the 3rd percentile, then it qualifies to be called growth restricted. As long as the baby is abnormal, there are no other pathologies. I hope that's also clear. We also do Doppler velocimetry. For Doppler velocimetry, we're going to be measuring the uterine artery Dopplers, the umbilical artery, the middle cerebral artery, and the ductus venosus Dopplers. So the first two, the uterine artery and the umbilical artery, they allow us to identify if there's any uteroplacental insufficiency. Whereas the last two are the fetal Dopplers, and they allow us to see what it is the baby's cardiovascular response to the hypoxia that they're undergoing. So as part of our assessments during surveillance, we'll not only do the growth velocity, but we also start now doing Doppler velocimetry. We also use CTG, radiograph, during the assessment if it's available. We also do the biophysical profile, which is quite easy to do the biophysical profile, whereby you're looking at different things that the baby is doing in utero. Is the baby moving? What is the tone? Are there any breathing movements? And also, what is the LICA? We can do those 4. But then in addition, we also need to do the CTG to make those 5 things. So for most of our centers, we don't have the CTG, but we can do the other things. So now before diagnosis, I go on to talk about the 2 recognized phenotypes for fetal growth. Because how we diagnose the fetal growth restriction will be a little bit different depending on the phenotype that is there. And it's early onset fetal growth restriction and late onset fetal growth restriction. So basically, it's just based on the date. If the fetal growth restriction is noticed at below 32 weeks, then we say this is early onset. If noted after 32 weeks, sorry, from 32 weeks and onwards, then we say it's late onset. That's how we are distinguishing this. And the prevalence, you'll see that it's lower for early onset fetal growth restriction, but much higher for late onset fetal growth restriction. Now, you think in your clinics, how many patients, babies are you picking with fetal growth restriction who are actually late onset fetal growth restriction? They are much fewer compared to the ones that you're picking who are small. That is because once the baby is small, you begin to think, there might be fetal growth restriction. But then when the baby is within the appropriate for gestational age category, then you don't think that they might have fetal growth restriction. So because we don't keep them under surveillance, that's why we are missing this. But actually, data shows that there are actually many more babies with fetal growth restriction who are large for who have late onset fetal growth restriction. So that's something that is very important for us to note. And then when we scan them for the early fetal growth restriction, these babies are generally very small. But then with late onset fetal growth restriction, these babies may not necessarily be small. They might just look like they are appropriate for gestational age. And then when we do our Doppler velocimetry, then there's a spectrum of Doppler alterations that involve all the Dopplers when it's early onset fetal growth restriction. You look at your umbilical artery, there's something wrong there. Then you look at medial cerebral artery, there's something wrong there. And as time goes on, also the ductus venosus becomes abnormal. So again, making it easier for us to pick up these babies. Whereas in late onset fetal growth restriction, all the other Dopplers may actually be normal. It may only be one thing, the medial cerebral artery, which may start to show some abnormalities, and which may make us think, could this baby be actually having fetal growth restriction? Then also in early onset fetal growth restriction, hypertensive disorders are actually more frequent as well. Again, when a patient comes with very high blood pressure, you also begin to think, could they have fetal growth restriction? But here in late onset, they may actually be normotensive. So again, it makes us miss these babies. And then when you look at the placenta, if we took the placenta after delivery for histology, what you find that there are lots of abnormalities there. There's poor placental implantation, spiral artery abnormalities, and then there's also, which is a sign that there's maternal vascular malperfusion. But if you look at the placenta of those with large for gestation, with late onset fetal growth restriction, this case, the findings are less specific. So the prenatal mortality of these babies with early onset fetal growth restriction is very high. But the prenatal mortality for the babies with late onset fetal growth restriction is low. That is when picked up. It's low compared to when they are not picked up. And then the main clinical challenge with the early onset fetal growth restriction is always management. Baby is 26 weeks, but they have all these problems. The Dopplers are abnormal and they're still very small. What do I do? Should I deliver? Baby is still too small. But then with the late onset fetal growth restriction, the problem is detection. But then it's easier for us to make a decision to deliver these babies because they are much bigger and usually they do well if caught in time. So now we finally go to diagnosis of early onset fetal growth restriction versus late onset fetal growth restriction. For us to make this diagnosis, this is actually based on international DLP consensus. What basically this means that a group of experts in fetal medicine came together and said that this is how we're going to make this diagnosis for early fetal growth restriction, late fetal growth restriction. So for early fetal growth restriction, as I said, any baby who with fetal growth restriction less than 32 weeks is said to have early onset fetal growth restriction. And for both, this should be in the absence of congenital anomalies for you to be able to make this diagnosis. So if for any of the babies, the abdominal circumference or estimated fetal weight is less than the 3rd centile, as long as they don't have any congenital abnormalities, whether you catch them at 32 weeks or lower or 30 weeks and above, then these ones will have fetal growth restriction. Or we can use also other parameters. If the abdominal circumference or estimated fetal weight is less than the 10th centile, these are basically small for gestational age babies. But in addition, they must also have something else. For you to say that they have early onset fetal growth restriction, then the uterine artery PI pulsatility index must be more than the 95th centile, or the umbilical artery PI must be more than the 95th centile. As I said before, these show that the uteroplacental abnormalities if they are more than the 95th centile, either uterine artery PI or umbilical artery PI. So with this, we can make a diagnosis that this baby is fetal growth restriction and it's early onset because they're less than 32 weeks. Now, when you look at the late onset fetal growth restriction, again, if the baby is small for gestational age, and then you're also continuing to follow its growth trajectory. If they just begin to fall off that and they've fallen by more than 2 quarters or more than 50%, then you say that they've late onset fetal growth restriction. We can also add on another parameter, which is called the cerebral-placental ratio, whereby you look at the middle cerebral artery PI and also the umbilical artery PI, you get a ratio of that. If it's less than 5%, again, you can say that this baby has fetal growth restriction and it's late onset. So as we do that, we continue to, we now have our diagnosis. And this baby will continue with the surveillance. What you find that there are going to be 3 scenarios that you may come across. In scenario 1, yes, you've made a diagnosis, the baby has fetal growth restriction, but all Dopplers are normal. So you call them after every 2 weeks, no need to call them every day. Scenario 2, again, you say that fetal growth restriction, but the Dopplers have now become abnormal. There's high umbilical artery PI, and there's low middle cerebral artery PI. Then in this case, you now call them more frequently. You call them every week because it means that there's something worsening. And then finally, in scenario 3, there's fetal growth restriction in the abnormal Dopplers. But how abnormal are the Dopplers? You look at the umbilical artery Doppler. Now there's absent end diastolic flow or there's reverse end diastolic flow. You look at these 2 graphs here. What you can see is that here there's absent end diastolic flow, and here there's reverse end diastolic flow. So when this is happening, this means that this is more severe, this clinical picture. You can also do your CTG then at that time if you have a CTG. And now you're calling these mothers every 3 days that you can see when is the optimum time for delivery. So how do you make the decision to deliver these babies once we've realized that there's a early onset fetal growth restriction? The only criteria that we should use when we are doing the scan, ultrasound scan, is the ductus venosus. All these other things may be worsening, but if the ductus venosus is still okay, according to the travel study, there's no need to panic. Just call them more frequently, do your CTG. If it remains the same, again, call them more frequently, do your CTG. We're trying to get a baby who's as big as possible by doing this. But once the ductus venosus becomes abnormal, what does it mean? Either there is no A wave or the A wave becomes reversed. Then in that case, then it's time for delivery. And this delivery ideally should be done within the next 24 hours. Whereas in late onset fetal growth restriction, again, 3 scenarios, maybe 3 scenarios. Scenario 1, again, the Dopplers are normal, but you say that the fetal growth restriction. Again, you call them after every 2 weeks, so no surprises there. In scenario 2, they're now elevated umbilical artery Doppler PI. Then now you start doing weekly Dopplers with biophysical profile score. Scenario 3, also in addition, there's no middle cerebral artery PI, or the cerebral placental ratio is now low, less than 5%. Now you call them more frequently to do the scans every 2 to 3 weeks, every 2 to 3 times per week, with also your biophysical profile score. Then in this case, when then should we make the decision to deliver? With when we're looking at the abnormal Dopplers, if the umbilical artery PI is more than 95%, if the middle cerebral artery is more than PI is less than 5%, and we've managed to push them 37 weeks, then as soon as we get 37 weeks, please let's deliver these babies. We don't need to keep them in utero anymore. But at any given point in time, more than 32 weeks, if the umbilical artery Doppler starts having reversed or absent end diastolic flow, then we immediately deliver. So this is very important because when you compare to those with early onset fetal growth restriction, we'll still struggle on and wait until the ductus venosus becomes very abnormal. But with late onset, as soon as the umbilical artery Doppler has absent end diastolic flow or reversed end diastolic flow, then we deliver. If there's fetal growth restriction, but the Dopplers remain normal all throughout until 37 weeks, then we'll deliver at 38 to 39 weeks. We don't go beyond 39 weeks. So I hope I've managed to explain a little bit on fetal growth restriction and also to clear some problems that we have That is when we say that small for gestational age is the same as fetal growth restriction. These are different. And also to make you aware that there are some babies who, if you scan them only once, you might not think that they are growing appropriately for gestational age, but they may actually be having fetal growth restriction. So the diagnosis of fetal growth restriction is not always straightforward. That's one. And all of us, wherever we are practicing, let's all be vigilant when we see pregnant women so that we risk profile them as soon as possible when they come to our clinics for the very first time to book. And then we'll put them under surveillance if they deserve to be put under surveillance. And this will lead to an early diagnosis. Because what we know is that early diagnosis of fetuses with fetal growth restriction helps us to closely monitor them and institute timely interventions, which may help to improve short and hopefully long-term outcomes for these babies. Thank you.